Okay, good afternoon. I appreciate everybody's coming and attending the Medicaid Oversight Advisory Board, our fourth meeting. And I appreciate we have a pretty heavy agenda, which is sort of typical in the past, today, and in the future. And so we have a lot of topics to cover and so forth. We'll go ahead and call the meeting to order and ask DJ to call the roll.
Senator Berg. Senator Carroll.
Here.
Senator Meredith.
Present.
Senator Richardson.
Here.
Representative Heverin. Representative Marzian. Representative Mosier. Representative Williams. Vicki Yates Glisson. Holly Harris. Joe Petrie. Steve Shannon. Senator Douglas.
Present.
Senator McDaniel. Representative Bowling. Representative Petrie. William Baker. Laura Sudkamp. John Hicks. Lisa Lee. Sheila Schuster. Stephen Stack. Tom Stevens. Co-Chair Rocky Adams. And Chair Fleming.
I am present. My co-chair, Senator Julia Adams, is not here today. She's taking some R&R, much needed R&R. Please make sure that your phones are silent. We don't want that to interrupt our discussions and so forth. What I would like to do before we approve the minutes, I'm going to change the agenda around a little bit in order to accommodate some schedules from our distinguished guests from U of L and UK. And then we'll have Representative Deanna Gordon come and talk about her bill that she's going to be filing. And then we'll go on from there. So with that, I'll take a motion on the approval of the minutes for August 27th. So moved by Representative Motor. We have a second by our Senator Douglas. Very good. Okay, gentlemen. Is there anything else? Oh, is there we have a voice vote. All in favor say aye.
Aye.
All opposed, like sign. Very good. Thank you. Okay, gentlemen. If you don't mind, when you get settled, just go ahead and introduce yourself to the committee. I just want to let y'all know the board should be aware and conscious that these two universities are very strong flagships. We have many good universities in the state, but they provide a lot. These two universities, U of L and University of Kentucky, provide a lot of information. And we've asked them to come and give a little history and a little bit perspective on what they're faced with, given with House Bill 1 that came down from the federal congregation. So with that, gentlemen, whoever wants to go first. I know this is not November 29th. We'll wait until that comes up. If you want to wrestle, whatever you want to do, but feel free, just introduce yourself and go ahead and you have the floor.
So I pushed the green button before you did, so I will go first. So my name is Mark Birdwhistle. I'm Senior Vice President for Health Policy at University of Kentucky.
And I'm Ken Marshall. I'm the Chief Operating Officer at U of L Health.
All right, Mr. Birdwhistle, would you mind putting the mic closer to your mouth as well as Mr. Marshall? That'd be great.
Is that better? Good. Thank you. So thank you for the opportunity to be here today. I think this has been a partnership between the University of Louisville and the University of Kentucky that dates starting back in 2019. It actually predates that. Both institutions have received supplemental reimbursement from Medicaid because of the patients we serve, and we both have agreed to take all patients regardless of their ability to pay. So this is long-standing, and what we'd like to share with you today, where we are and some of the outcomes. So this slide basically covers both UK and U of L. We are jointly in what we call the State University Teaching Program. We began in 2019. I always point out that this was initially approved under the Trump administration, working with their team. This was brought about by the Medicaid managed care rule of 2016, which said any supplemental payments that were paid through managed care organizations had to meet the requirements of having quality value targets, having financial risk, and having accountability. And what I think we both have got stories to share is how this program has worked. Our current preprint to cover us for the period January 1, 2026 was submitted on November the 11th of 2024. We are hoping, we have our fingers crossed and everything else that we can to hopefully get approval of that in the coming days. So this has been a journey. So we started out the program because this whole value-based endeavor was kind of new to us, especially in the Medicaid realm. This has been done in great partnership with the Cabinet for Health and Family Services, Department for Medicaid Services. We've all learned together on how do we create value, how do we produce outcomes for our population. And I think you can see over the tenure, I won't read all the little columns to you, but we've increased the number of values that we've had to meet metrics on. At the same time, we've increased our financial risk. So this has been an exercise that has been nothing but short of transformative. The next slide, because Ken and I, this is not the first Mark and Ken show. We've done this a lot in Washington, D.C. And we always point out that there are 3 states that have what we feel like are credible value-based programs. And Kentucky is probably the most credible because we have more measures, we have more money at risk, and we've got the outcomes to prove it. And that's not just the university programs, the ATRIP program that all of the other hospitals have. And we understand there's some other plans out under development for other physician services that are very similar in nature to what we've got in Kentucky. We've advocated that what we've done in Kentucky could potentially be a model for the nation. So the challenges, we've all testified forever, the challenges of obesity, smoking, low education, decoding cancer risk. This is what this program is about. This is how do we curve that trend? How do we not be the worst state in the nation for all of these incidences? Next slide is very busy. This is UK only. I think Ken's probably got some slides that are very similar. But you can see the bright blue ones, of course, being UK, sorry, I had to make them bright blue. Those are pediatric measures. So this is very driven on pediatric, improving patient outcomes in the pediatric populations. And that is attributable to the focus from Commissioner Lee and Secretary Freelander. When we were developing these metrics, they were pretty adamant that we would be focusing on Kentucky's children and getting ahead of that curve. This slide, I got some criticism when I was doing Washington, D.C. visits. They would say, Mark, these are just cupcake measures. You're just writing this plan so you can be guaranteed of getting the money back. And this slide shows these are not cupcake measures. The lighter blue little sidelines on each of those columns shows where our targets were set. The faded yellow lines, that is where the national, that goes sideways, the yellow lines show that's where the national average is. So this has pushed us well above the national average in everything that we've had to do. breast cancer screening, colorectal screening. You can read the numbers. Well baby visits, H1C measurements. So these are not cupcake measures by any stretch of the imagination. Now, this is the University of Kentucky response from the beginning of the program in 2019 to 2025. You can see how our journey, how many points we have moved on depression screening, BMI, H1C levels, breast cancer screenings. This has been a stretch. Our faculty and staff have all embraced this. These are probably the best measures, and I think U of L's are very similar because we're in this plan together, that of any plan in the nation. And the reason I've color-coded these, for the next slide, part of my lobbying argument is these all align with where Secretary Kennedy is going with making America healthy again. And we've got a head start here in Kentucky, which is surprising to a lot of people in Washington, but this has been simply transformative. And my last slide, if you look at the national health rankings, where we were in 2020, where we were in 2014, we were 47th. 2024, we had risen to 41st. Just 1 year later, we were at 37th. Now, I don't think Medicaid directed payments gets all of the credit. It gets some of the credit. I think Medicaid expansion, having coverage for folks, having this value-based program in place, focusing on wellness, having community health workers in the homes trying to get people the care they need, has resulted in this. And this last slide has gotten a lot of traction in Washington. So I'll turn it over to Ken now.
Thank you. Can you slide that down?
You wanted him to do it.
Can
He can
pick up my slide? And I'll tell you when to turn. They should be loaded there. Yep.
We'll charge you for that, his services.
I figured you would. Thank you. Once again, I'm Ken Marshall. I'm the Chief Operating Officer at U of L Health. And we're an academic health center in Louisville with over 2 million annual encounters, patient encounters annually, and 14,000 team members trying to make sure Kentucky wakes up tomorrow healthier than it did the day before. I first want to thank you for the opportunity to speak with you about the University Directed Payment Program. It's a vital part of the Medicaid program in Kentucky. The University Directed Payment Program has proven to be a national model, as Mark mentioned, that has demonstrated quality improvements and savings for the Medicaid program. I'll also address the impact the reconciliation bill signed by the President on July 4th, and that in 2.5 years will have, we believe, significant impact on the program. But before we start, I do want to share my sincere appreciation for this body for taking the time to understand this program and your interest not only in Medicaid, the directed payment program, but also the health of Kentuckians. So let's go to the next one. Next, the one after that. So let me start and get into a little bit of understanding of what the program is for academic medical centers in Kentucky. Like testimony that you have heard in the past at prior meetings about the broader HRIP directed payment program, the University Directed Payment Program allows Kentucky's two university health systems, U of L and UK, to draw down federal matching dollars. However, unlike HRIP, in the university program, provider tax funds are not the source of the matching funds. For the university program, the matching funds are provided for through the universities. Let's go on to the next one. So, As a result of the federal matching program, we benchmark against the average commercial insurance rates, which helps close the gap between the base Medicaid reimbursement and the actual cost of care. The state-federal program creates access to care for Medicaid patients and supports our education and research missions that improve the health of all Kentuckians. So why does it matter? The current directed payments are essential for access and stability, especially in the state's academic centers, which are both a safety net hub and a resource for specialty and subspecialty care for the state. They ensure our hospitals remain financially viable to serve low-income patients and provide high acuity care in specialty areas such as transplant, high-risk obstetrics, oncology, and trauma services, just to name a few. It is also important to note this program also supports Kentucky's medical education pipeline, training future doctors, nurses, and allied health professionals, which is a core function of all academic medical centers. And because of the 20% of the payments are directly tied to outcomes that Mark mentioned, Kentucky is at the forefront nationally with a value-based design that improves outcomes and saves scarce resources. Let's go to the next one. So let me give you some highlights. Earlier this year, we went back, like UK did, and studied our quality results. Over the past 3 years, U of L Health has made measurable improvements across quality measures such as tobacco cessation, diabetes control, depression screening, cancer screenings. We have the same scorecard that Mark showed just a few moments ago. These improvements aren't just numbers. They represent healthier communities and real cost savings. In fact, the improvements at U of L Health alone represent an estimated $137 million in annual cost savings for the Medicare program. Let's go to the next one. Looking forward, we also are mindful of future risks. The federal reconciliation bill signed on July 4th proposes a 10% annual reduction in directed payments for universities and other hospitals for 10 years beginning in 2028. Now, before I make further comments on the reconciliation bill, I do think it is important to thank Congressman Guthrie and recognize his efforts in Congress to find a path to compromise that supported the Medicaid program and the health needs of Kentucky. During this entire process, he did prove to be a consistent champion for Kentucky and understood the value of directed payments and the impact it can have on the health of all citizens. Unfortunately, the congressman's vision was not realized in the final version of the bill. And as a result of the federal legislation, the first year's reductions will be a $75 million negative impact for U of L Health. At the end of the 10-year period, the cumulative cuts will be approximately $600 million negative impact just for U of L Health alone. We are concerned that the upcoming cuts to the state-directed payment program represents a ceiling, but not a floor. Also, when taken in totality with other upcoming Medicaid restrictions like work requirements and the need for U of L to plan for program payment reductions, the impact on U of L and the Commonwealth will be felt even before the cuts are implemented. And while we will use the next 2.5 years to responsibly prepare for these cuts, we expect the reductions of this scale, we expect to ultimately impact access to care, training capacity, and Kentucky's ability to sustain its value-based model that benefits all the citizens. So the bottom line is University Direct Payment Program has been a literal lifesaver for many of the citizens of the Commonwealth and created a foundation for improved access to care, workforce training, and lowering the cost of care. It's a national model that started in Kentucky. And while we prepare for the fiscal realities that are facing us at the federal level, I promise we will not waver from our mission to continue to serve the health needs of the Commonwealth in the best ways possible. We will continue to be committed to improving the health of our state. Thank you.
Thank you very much, gentlemen, for your for your presentations to give us a little better idea what's going on. Mr. Burwhistle, I know Mr. Marshall mentioned about $75 million would be a first year. Did UK go through and come up with an estimate on that as well?
Yes, we have an estimate of ours is probably around 100 million.
About 100. So total between the both of you is 175 million times 10. That's 1.7 billion, roughly. Okay.
So I have a little bit more positive view of that one. That's what's out there. Time is our friend. We've got support from the congressional delegation, both in the House and the Senate, to look at creative alternatives so that what is proposed or what is in law for 2028 hopefully will never materialize. I've seen multiple reconciliation bills in my tenure, 45 plus years. Many of these start out as a direction of where things need to go, but very often they never turn out to be the destination. So my positive thinking on this is down the road, we can change that direction, but we have to plan. We have to plan for where this is. UK is planning, has already started planning about the eventuality, but my hope is to have a recognition that there could be a different destination.
I just want to echo Mark's optimism because I think it's fair to hope and read as at least the tea leaves that we see that there could possibly be a delay in this. I hope that's possible because I think we can turn on a dime. But as Mark alluded to, I think we are both living in the world that we know today and preparing for what the world that we have been told is going to happen in 2028. And for both of our systems, moving them is not something that can happen in a day. I mean, it takes a while to, especially with the possibility that is coming down the road, takes a little bit of prepping for. But I share his optimism.
Very good. Senator Meredith, you have the floor.
Thank you, Mr. Chair. And very brief question, kind of add insult to injury. What's the potential impact of loss of 340B funding to each of your respective organizations?
Well, let's I don't know the exact number, okay, off the top of my head.
I'm going to hold you to it.
I probably get it to you, so I'm going to wait till I get the right one. But I think this change in directed payments is a catastrophic change. I mean, I can't. The numbers just don't point to any other way. And I think if you add on top of that 340B, either a reductions or changes in the program that don't allow us to access that pricing as we do now, will add insult to injury. And I don't have exact number for you right now.
Mark?
I don't have a number with me either. I think 340B is it's very complicated. If anything, I think it's more complicated than Medicaid, which says a lot coming from me. And I think there's a lot of misunderstanding about how the program works and how the discounts get provided to certain entities such as UK and U of L, where we can buy medications at a deeply discounted rate so that we can take that revenue that is generated because we're able to purchase at a deeply discounted rate and provide services for others where Medicaid and other insurance drop off. And I think we need to do, not just UK and U of L, I think the industry as a whole needs to do a better job explaining what the program actually is. It's a discount on medication cost. There's not state or federal revenue associated with it, so that we can generate cost savings to allow us to reinvest in services that folks need, such as transportation and access to physicians, et cetera. But we will get you that number as well.
Just a brief follow-up. When we had testimony last session on 340B specific to U of L, Tom Miller gave me a letter, said that the U of L's operating margin is at 1%. Is that...
That's generally, yeah. That's
General.
about how we end up the year.
Right.
Yeah.
Well, I remember when we passed a legislation 4 or 5 years ago to provide the funding for purchase of Jewish Hospital, that Dr. Benaputi at that time said that probably need to generate about a 6% return to be financially viable. Is that kind of your target as well for both organizations?
Yes.
And you're roughly 1%.
Yeah.
That's the same with medical center?
Yes.
All
Our
right.
target is 6-7.
All right.
Thank you,
Thanks,
Senator.
Mr. Chair.
Senator Berg, you have the floor.
Thank you, Mr. Chairman, and thank you both for your presentations. First of all, as far as your optimism, I just want to say from your mouth to God's ears, because this is really, really important. But second of all, I just want to make sure that people out here in this state understand the actual quality of health care that we have in Kentucky at these institutions that is way, way, way above what you would normally assume a state like Kentucky would have. These are both premier research institutions that are doing amazing work in this state. Just as a personal note, when I was diagnosed with breast cancer, obviously I had the option to go anywhere in the country, and I had some friends who were really, really hounding me to do so. And with consultations throughout the country, I was told, Karen, stay where you are. If you are at University of Louisville, you have absolutely everything you need. That's a really important statement for people to understand. So I just want to say thank you for the services you have offered to the constituents of this state, and I will pray with you that something is done, because there is no way that our healthcare systems can sustain this amount of depletion of funds in the future. It just is not. It will not survive. So thank you.
Thank you, Senator Berg. Representative Mosier.
Thank you, Mr. Chairman, and thank you very much for your presentation. I just want to congratulate both of you and all of us really for improving the numbers in Kentucky so significantly. It's exciting to me to see that not only the ATRIP, the additional kind of subsidies that hospitals are receiving are improving our care, improving access to care, but that the return on investment is real. And I did want to point out that Kentucky was the only state who was noted to have had a 100% score in the comprehensive cancer control news that was released last week. We are putting great policies in place. We need to continue that. And I think that we have example after example of how things are improving and working. So that's my comment. I would like to dig down more on the value-based structure of payments to really understand myself. Maybe I'm the only one here who doesn't have a clear picture of what that looks like. So I want to better understand that and how it's working to I don't know, bolster what we can do. I don't know. Do you have a general comment about that?
So I'll start. Mm-hmm. What we've done, we've built this from ground zero, working with our colleagues at the cabinet. As I said previously, we've had to learn where are we currently on these measures? And then we look at the national average. What does that look like? Then we go and say, well, can we reach the national average, or should we strive for something beyond the national average? And that's the history of this program from 2029 to 2025, 26, is we hold ourselves accountable for meeting those metrics. Is there anything magical about those metrics? Not really, but managing has been transformative. We have involved nursing staff, clinical staff, physicians are actively involved in this every week. Everybody is looking at their data because the magnitude of the dollars is so significant. But now it's it's embedded in our cultures at both organizations. And we tried, before this program came into existence, we tried to get people's attention on this, and it was difficult. But this program, the magnitude, the number of measures, the 21 measures, and the stretch goals, and we agree with the cabinet on where we're going to be on a running 3-year basis so that we can hold ourselves accountable. This is where we want to be. Some of the measures we've had to put into a category called maintenance because we've got them to where they need to be. What else? Let's go find something else that we need to look at in order to meet the needs. And depression screening for adolescents is one of the ones that came on the horizon. So it's a living, breathing process.
Okay, thank you. That helps a little bit. And if I may just make one more quick comment, I promise to keep it quick. I appreciate your comments about data and data collection. I think it's really critical that we have the right data to really inform our policy decisions and to really, I don't know if it's even possible, but to really understand the true cost of healthcare. I mean, there's so much money flying around. I don't know if we can peel back the onion to really understand what we truly need. And I think we need that to be able to really understand which programs to continue, which to improve upon. I think that's really the point of this whole Medicaid oversight. So I think that the more transparency we can get around the costs and the data, the better off we'll be. So, thanks.
And I think this will afford a treasure trove of data upon which decisions can be made. Quite honestly, the progress we have made here, I would have never envisioned us getting to this point. But it's really been helpful when Ken and I would go to Washington and work those halls. We could show those same slides. That's hard to argue with. And we're very hopeful when the new plans come out that Kentucky's model will be at least significantly a big component of what the national model comes out to be.
Thank you, gentlemen, very much. Mr. Marshall, do you have a last?
I do not.
Okay, very good. Thank you all very much for coming. We do appreciate your time and your good words and your good thoughts. We look forward to working you all down the road as well.
Okay,
thank you.
Thank you all.
And let's see, our next on the agenda is Representative Gordon, and she has a bill in regards to assisted living waiver that she'd like for us to hear about, and I imagine she will file this coming January.
Thank you, Chairman and members.
Your floor. Go ahead and introduce yourself, Representative.
Okay,
you have
yes.
the floor.
I'm Representative Deanna Gordon. I'm the state rep in Madison County District 81. And this is a topic that is not new. Many of us are very passionate about this. And the discussion has always been how to go about it and that type of thing. So I will be brief. But I would like to mention that this week does mark Assisted Living Week, a time which is dedicated to recognizing the importance of the quality of care options and the vital role assisted living communities play in supporting seniors and their families. This bill draft would extend Medicaid coverage to assisted living services. For reference, Kentucky is only one of 3 states that do not offer Medicaid coverage for assisted living services. Right now, Medicaid will only cover the cost of living in a skilled nursing facility. This has left patients all over the state who require long-term care with limited options. Unless a patient has the funds to pay for these services out of pocket or a loved one can care for them full-time, a nursing home is often the only option. This legislation seeks to close a huge gap in our state's long-term care system by ensuring Medicaid patients have access to assisted living services. With an aging population and growing economic pressures on families, Kentucky must offer a more affordable alternative to nursing home placement. Assisted living is a cost-effective, long-term care model that provides care for patients who do not require full, medicalized, institutional, structured care, such as a nursing home. As you know, assisted living services help with daily living tasks, personal care, medication management, and much more while preserving the patient's independence. Allowing Medicaid to cover these services would provide a middle ground for patients all over the state with the option of a less restrictive, community-based environment that would significantly reduce taxpayer spending. Currently, the average monthly cost of a private room in a skilled nursing facility is between $12,000 to $14,000. By comparison, assisted living services cost an average of around $3,400 per month, significantly less expensive than the cost of nursing home care. By allowing Medicaid to cover assisted living, Kentucky could provide the appropriate level of long-term care for patients while easing the strain on the state budget and potentially save hundreds of millions of dollars annually in Medicaid spending. Also, too often loved ones are leaving the workforce or cutting back on hours to provide full-time care because Medicaid does not cover assisted living. Families should not have to choose between earning a living and caring for their loved ones. By expanding this coverage, we can ease that burden, as almost every other state in the nation has, and keep more Kentuckians contributing to the workforce while ensuring their loved ones are cared for. And I think I'd like to share or steal Dr. Birdwhistle's comment about this is meant to be a direction. It may not be the final destination because there's many different variables. There's different ways that we can accomplish this. But I think the goal is that we just need to be able to provide this service, especially since we're one of 3 states that do not.
Thank you, Representative. Any question? I think Senator Berg first, if you don't mind. Ms. Marsden, just hold on for a second. Go ahead, Senator Berg, you have the floor.
Thank you, sir. Very, very, very interesting subject. I mean, extraordinarily needed and interesting. Okay, I have a question, though. Right now, we don't have any waivers for assisted living, but we are apparently willing, as a state, to pay family members to be caregivers for people that otherwise really should be in an assisted living facility. Is that correct? And would this have any impact on that?
Well, I don't know that we need to pay family members to be caregivers, but at the same time that it would allow those services to be provided in the home or in the most appropriate environment. So I think that question is one of those things that would be something that would be ripe for discussion before.
Follow up, please. Mm-hmm. Follow up. I'm just thinking this may be a way to actually pull in federal dollars and quit spending some state dollars, because I personally know people that would do well in assisted living mm-hmm. who are being cared for on state dollars by a family member who should otherwise be at work. So I'm just curious about that. Thank you. Thank you.
Senator, sorry to interrupt. There is a waiver for patient directed payments for that. We do have that in there. And you have to qualify in order to be a caregiver if you're associated or if you're a relative or a family member of that particular person who needs it. So there is something like that, but this could be included in that or surround that to a certain degree. So we do have that. It could replace it, right? Yeah, but yeah. Let's see. Representative Margin, you had a question.
Thank you, Representative. I think this is a really good issue to pursue. And my question kind of goes along with Senator Berg's is if someone wanted to stay at their home, which a lot of people do, but say there are no caregivers, could they get home nursing care coming once a day, or a nursing assistant or anything like that come and maybe make a meal and make sure they're getting a shower and medications and that kind of thing?
Right, and there's different levels of waivers, and this is kind of open-ended, leaving it up to the cabinet at their discretion at this point, but we could kind of state which ones that we wanted to apply for, or what services that we wanted to be included in that type of thing, but that would be one example, yes. I think the goal is just to allow patients to age in place and to get the most appropriate care without necessarily having to go into a skilled facility if they're not at that point.
Good. Thank you. Dr. Schuster. I'm sorry, Representative Marsden, you finish?
Oh, yes, thank you.
Yes, ma'am. Dr. Schuster, you have the floor.
Thank you, and I really like this idea, but I have a question. You're talking only about a home and community-based waiver, right, Representative Gordon, where the services would be offered at home or in the community, not in a skilled nursing facility.
Right, it would not be in a skilled, well, unless they had a different wing or something like that, but it would not be necessarily in a skilled facility. And then as far as the waiver approach, there's the states across the nation have accomplished this two different ways. Sometimes it's as part of the 1915C, it's just listed as services. Sometimes it is its own standalone complete waiver. So again, those would all be things to be kind of hashed out. This is just kind of bringing the umbrella at this point.
Well, I'm interested also in whether assisted living might be paid for by Medicaid in a skilled nursing facility, because right now that's not possible. So I don't know, I haven't read the bill carefully, but is that a possibility, or is yours written to be community-based?
It is written to be community-based.
Okay. So it would still not cover those services in a skilled nursing facility?
That's correct.
Okay. Thank you.
Let's see. Our last question is Ms. Harris.
Thank you, Representative Gordon. I do have a couple questions or comment. So in Eastern Kentucky, we truly lack these type of facilities. So do you believe with a waiver such as this for assisted living, do you think we would be able to attract providers into the Commonwealth to build assisted living facilities, especially in Eastern Kentucky? Because we are faced every day. I have 12 hospitals in Eastern Kentucky, and we have patients in all of our hospitals that are waiting on skilled nursing facility beds because that's all we have, and we can't even get placement in those.
Yes, I do believe, and I believe it's a little bit of the Chris had this, and I had this discussion today. It's a little bit of a chicken and the egg. I think once the waiver would be approved and the slots are available, that then we would have providers that would come in to look to fill that gap.
Yeah. Thank you, Ms. Harris. Thank you, Representative. Appreciate you coming in and giving us your thoughts and opinions on this particular bill. And just I guess be mindful, even though when we push through a bill, and it's probably for all legislators, when it comes to waivers and so forth, it might be a good idea to have in your back pocket the financial impact, given that we're faced with a significant amount of challenges over the next several years. So it'd be good for us to be mindful of that.
Yes, absolutely, and we looked into that, but of course they don't take into account the savings at this point. So, but we are looking at ways to get some of those metrics, because that's the impact that we're wanting to have for sure. Thank you.
Thank you.
Appreciate
Thank you
it.
very much. Thank you. Okay, next on our list is an update on the 1915C home community-based waivers. We have Ms. Huffman and Ms. Hancock. If you don't mind, just go ahead and get settled down, introduce yourselves, and you have the floor. And if you don't mind, just be very concise. We still got about an hour and 45 minutes roughly. But we do have a couple of presentations. Just to be short and concise, we appreciate it. If there's anything that we already know about, in your opinion, just go ahead and go through all that. If not, we'll ask. Thank y'all.
Good afternoon. My name is Leslie Hoffman. I'm Deputy Commissioner for the Department of Medicaid.
Just pull it to you closer.
Leslie Hoffman, Deputy Commissioner, Department of Medicaid.
Carmen Hancock. I'm the Division Director for Medicaid Long-Term Services and Supports.
Chair Fleming and members of the committee, thank you so much for having us here today. We were asked to come and give you some information related to our 6 1915C waivers here that we have in the state of Kentucky. Now, you've heard me speak before, but I'm going to go over just high level. These are the 6 that we have. The acquired brain injury waiver, which is totally administered by the Department of Medicaid Services, and we established that waiver in January of 1999. We also have the acquired brain injury long-term care waiver that is also totally administered by the Department of Medicaid Services, and we developed that waiver in October of 2007. We have the model waiver 2 that we are also administer at the Department of Medicaid, and it was established in October of 1987. So you can hear that some of these are quite old. We have the home and community-based waiver, the HCB, that is administered by the Department of Aging and Independent Living. That one was established in 1987, and that one holds the title of the umbrella. So these are all 1915C home and community-based waivers, and HCB was our first, and not knowing that 5 others would come later and afterwards. So that one was actually named and had the most slots to begin with. We also have the Michelle P. waiver that is administered by the Department of Behavioral Health, Developmental, and Intellectual Disabilities. And we have the Supports for Community Living that is also administered by our Department of Behavioral Health, Developmental, and Intellectual Disabilities. And I won't go over this whole slide, but just to give you just a brief overview, these are the 6 waivers listed in the blue on the left and what populations can be served. So one of the criteria for CMS is that you normally, for a home and community-based waiver, you would design it for a particular population. It needs to be carved out and have special rates or limits or durations and those kinds of things. So you have the acquired brain injury waiver, and the acquired brain injury waiver serve those individuals with acquired brain injuries that are in rehab in nature. They're still seeing potential, and they are trying to return home into their own home and own community. You have the acquired brain injury long-term care waiver, which kind of speaks for itself. We developed that one later because we realized that members were going to meet a plateau in their rehab and still need long-term care services. So we wrote that one later. You have the home and community-based waiver for individuals that are elderly and or members that are disabled. And I would just, mention too, you will notice that the home and community-based waiver and the Michelle P. waiver have different dates, and I'll go over that in just a second. You have the Michelle P. waiver, and that is a personalized community-based supports for individuals with intellectual and or developmental disabilities. And then you have the model waiver 2 for individuals who are on ventilation or ventilators and up to 12, actually it's 12 hours or more a day. And you have the Supports for Community Living, which is a personalized community-based waiver to support individuals with intellectual and or developmental disabilities in their own homes and in their own communities. One of the things I'd like to point out in the next column over are the waiver effective dates. So these may vary. We most recently with CMS was able to align at least 4 of those, and it is normal for waivers to have different waiver years because of the very reason of the implementation dates that I told you. It just kind of flows with them, and when we made changes in what the dates were, the CMS approve those waivers. So the last amendment was effective May the 1st, and then you'll see that the home and community-based waiver is actually on a new waiver year that just started August 1, and you'll see that Michelle P. waiver just started, or will start October 1. So these waivers run on a 5-year period of time once that they are approved. We have a pretty significant quality assurance review by CMS every 3rd year of the 5 years of the waiver. Okay, so the next one is the 1915C HCBS slot allocation, and I'm going to go through these slow and go over them again because I know folks sometimes get confused about what the meanings are for the waiver slots. So oftentimes we call slots opportunities because slot sounds a little bit, not personal, but for today's meeting we did call it slot allocation. So you'll see the waivers listed on the left-hand side. That's the 6 waivers. You'll see the funded slots, and the funded slots mean that we have received legislative appropriations to add the cost of what slots would be into the budget, and we have received approval. Once we receive approval, then we have to do an amendment to the waiver, and we have to ask CMS for the same thing. You can't just, even if we're given the appropriations, we still have to ask CMS for the authority to add. If we're not doing our due diligence, if we're not in good standing, or anything like that, CMS doesn't have to say yes to adding the slots to the waiver. We've never had that problem, but they do reserve the authority to do that. You'll see the field slots there, and the field slots have names attached to them. They are someone in a slot that has went through the process. They have financial eligibility, they have medical eligibility, so they meet the criteria of the programs that I told you about, and then they've actually had a prior authorization, and they're actually receiving services and providers are billing for them. So that's the field slots. Then we come to the allocated slots, and that is a slot that has been given to someone and that they are in the process of seeing if they're eligible. So you've got the financial eligibility. So members may not meet financial eligibility to be in Medicaid. They could not meet that criteria, and they have appeals. They have a due diligence we have due diligence for appeals, and then they also have to see if they're medically eligible and they meet the diagnostic criteria for each one of those waivers that I explained earlier. So this process can take a little bit of time. Just as a note, allocation periods are not predetermined, and they take time based on each individual. So it might be Leslie's time might take a different amount of time than Carmen's time. So they all have these different time periods they're on once we say go forth and see if you're eligible, and you have an opportunity to be into the waiver. And then so the ones that maybe wouldn't be eligible for financial, they may appeal or they may not appeal, and those that are medically not eligible, and they may appeal or not appeal. But whatever the decision is, for whatever reason that somebody might not take those slots, they roll over into the next month. So there's all these churns, and I can explain the churns a little bit later. So then you also have the section that's called available, and that's the one I really wanted to go through. So any slots that are reserved for a program called Money Follows the Person, and I can explain that to you as well, or emergency slots that may be earmarked and reserved per CMS approval for Center for Medicare and Medicaid Services for the SCL waiver, the Sports for Community Living waiver. And then we have all those rolling slots that I was telling you about. So it's not uncommon if this is just an example, maybe allocated, let's just say 250 slots. 50 slots, maybe folks, they don't want it. They've moved out of state. They're on another waiver. They've passed away, right? And so, or they've unfortunately, gone to a nursing home, or for whatever other reason, they might not take that slot. So those have to roll over to the next month. I was going to mention the Money Follows the Person program. If you're going, why do you reserve Money Follows the Person? Same population. So we have people in nursing facilities and intermediate care facilities, ICF IIDs, that want to be able to move out into the community and be in a waiver, okay? And oftentimes they can't unless they have extra supports. So we started, this is over a decade ago, a Money Follows the Person program to help people in ICF IIDs and nursing facilities and two psychiatric facilities, I believe, move out. So we give them extra care, extra coverage. We have funds to pay for a new bed if they need it. Maybe they're in a nursing home and they need to go back. They want to go back to their home, but it needs a new roof or a new ramp. And so those are the things that Money Follows the Person can pay for. But we have to ensure to CMS that they have a place to go. The grant lasts 1 year. So on day 365, that following next day, they go into a waiver slot. So we had to develop a transition plan that CMS would approve. So there we have reserved spots per CMS's approval for just a couple, and it's just a handful. I was going to share that with you. There's 5 slots for ABI LTC reserved for folks that are coming out of ICF IIDs and or psychiatric facilities or nursing homes, 150 for the home and community-based waiver, 10 for the SCL waiver, plus 225 reserved for their emergency. All of this is approved by CMS. This is not just things that Kentucky's come up with. And then 10 for the model waiver too. So I just wanted to share that with you. One other caveat that I wanted to share is that you will see the total on the wait list. There's currently 3 waivers out of the 6 that have wait list. If you total those up, it's 18,788. When I mentioned to you earlier that some may be on other waivers, we have folks that are on more than one wait list, or folks that are on a waiver but they want to be in this other waiver. Okay, so if you unduplicate the member, Carmen or Leslie, it's 16,373. So I just wanted to share that with you as well. Okay, and this is just some general HCBS wait list information I believe that was requested. So we broke out wait lists by time frame. So you'll see the 3 waivers that we have a wait list, and we divided it out by less than 6 months, 6 months to a year, 1 to 2 years, 2 to 3 years, 3 to 4 years, 4 to 5, and greater than 5 years. So that's the 3 waivers that have a wait list. And then at the bottom, we divided out what maximum days of stay on the wait list for HCB, Michelle P., supports for community living, and the average day on a wait list. So complexity of the wait list. Now I wanted to explain this. So if you took the whole entire wait list that we have, let's just start out with the 18,000. And then you reduce it by the duplication. That gets us down to 16,000 something. Then you've got 14.8 of the people on the wait list are on more than one wait list. That's the duplication. You've got 31.1 of the people on a wait list that actually have an allocation, to start in another waiver. You also have 86% of those people that are on the wait list that already have Medicaid. So they're receiving state plan services. They're not going totally without. And then if it's children, we have the EPSDT benefit, and that would be for anything that's outside of the state plan that children may need, and that's the early periodic screening, diagnostic, and treatment benefit. For example, it might be that a child this is just an example, but might need an extra oral hygiene visit. So if we pay for 2, this would pay for 3. Or we pay for a pair of glasses every 6 months or every year. They could pay for an extra pair of glasses if needed. So communication devices that maybe Medicaid's not covering. So they can cover those outside things for children. And then I'm going to just go over the churn, and then I'll turn it over to you. Is that okay? I feel like I need to go ahead and go over what we call our churns, if you don't mind, and then I'll turn it over to Carmen for the rest of the presentation. So last night I was trying to think how I could explain that available section to you, because folks want to know, why do we have available slots and yet there's a waiting list? So I thought I would go over that. So I'm going to use the home and community-based waiver, HCB, as my example. We currently have, with state fiscal year 26, we have 17,800 slots. On the slide that I showed you previously, there's 1,143 available. So there's a couple of things that occurred there. The state fiscal year would have rolled out in July, so we're still going through those 500 slots that we just recently received in the new budget appropriation. Then we also have those ones that I told you about that roll over from month to month. So we have the 500 new slots, we have a rollover from month to month, and that usually averages us about 200 assessments per month, or 200 new assessments per month. We also, outside of the rollovers and the deaths, which we're allowed to allocate month to month, we have other slots that are vacated from a previous year. So HCB, if you remember, I showed you on the earlier slide, they're in new waiver year. They just started new waiver year. So they also have those slots that can be reallocated from previous waiver year. There's 5 waiver years, and at the end of the waiver year, anybody that's left or vacated any of those slots in the previous year, we can reallocate those as well. So that's an average of 125 per month. So far we've got 500, 200, 125. The monthly assessments. So everybody that's currently receiving, if you have family members that are on the HCBS waiver, you have an original HCB assessment typically, and then you'll have a reassessment annually. So the reassessments on the 17,000 folks that we have usually runs about 1,400 a month. So I'm adding all these in so you can see why there might be a 1,143 available because of all these rolling numbers. And then, of course, we've got the MFP reserves, which are 150 per year. So I was just going to go over that with you because I know it's hard to understand about what's available when we have a waiting list.
Okay, thank you, Leslie. Let me make sure I've got this right. Okay, so I'm going to take you all through the process of accessing waiver services for a new applicant. And Leslie mentioned earlier that actually there's 2 different processes that are running sort of simultaneously. One of them is the Medicaid eligibility process. That's a different application process. The other one is the waiver application process. So I'm going to focus on the waiver application process just for the purposes of this presentation. So we have a nice little roadmap there. The first bubble, apply at connect.ky.gov. That is one option. Another option would be to go to your local community mental health center or your local area development district or area agency on independent living and aging. Any of those locations are able to take your waiver application. Along with the waiver application, there are certain documents that are required to be provided depending on the waiver. Most of our waivers require a MAP 10, which just very simply is like a physician's statement of need and clarification and certification of diagnoses for the applicant. The SEL waiver, we really want to see like a psychosocial evaluation, that sort of thing. So depending on what it is that you're applying for, you'd submit your application and the supporting documentation. The application is reviewed. If during the course of that review, it's determined that the application is complete and the applicant has met the specific targeting criteria for the waiver, which Leslie went over previously, then they might have a slot reserved, and they would be notified that you've got a slot reserved if there's a waiting list. So, for instance, our ABI waivers, the Model 2 waiver, those don't have waiting lists right now. But if it's someone, again, based on numbers, the majority of folks are applying for one of our 3 big hitters, so home and community-based, Michelle P., or supports for community living, SCL. So you'd be placed on the waiting list. You'd have your slot reserved, and then you'd sort of hang out there. You're going to get a notification every year that you still have your slot, letting you know where you are on the waiting list and asking if you want to stay there or if there have been any changes. Have there been any changes to medical condition? Have you moved? Have there been changes to income, that sort of thing? So that happens annually. And when that slot opportunity actually comes up, then you get from the place of waiting to allocation. So then you have a slot allocation. At that point in time, there's going to be some contact and there's going to be some communication letting you know that you've been allocated a slot. An assessment will need to be conducted. This is a functional assessment. And again, depending on the waiver, there are different assessments that are conducted, and they're conducted by different groups. Leslie's been using HCB as an example. So to stick with that same line of thought, in our home and community-based waiver, we have a team of nurse assessors through the University of Kentucky that go out. It's about 40 assessors. They go out and they cover the entire state to complete those assessments. So again, following the logic from Leslie earlier, that churn number is typically somewhere close to 1,500? 1,500 a month. That's before we even get to our new slot allocations for assessments. So those assessors are assessing across the entire state. So just keep that in mind. The assessments conducted, again, this is an independent functional assessment that is submitted and reviewed. And at that point, we make a determination as to whether that person meets the level of care and the eligibility requirements for that particular waiver. That is sort of happening in concurrently, the level of care determination, with DCBS also doing an eligibility review for Medicaid to ensure that this applicant has a waiver compatible type of Medicaid, so that if they were up and running and ready to receive services, they could be billed appropriately. So if a person meets level of care, they're then notified again, they've met level of care, you need to reach out to a case manager and start working on your person-centered service plan. So that's the next step. Get that person-centered team together. This could be friends, loved ones, family members, potential providers, really anyone else who the participant wants to have involved should be there sitting at the table with this in developing this person-centered plan. That goes again in for another review, and as long as the services are authorized and they're deemed appropriate and at the correct level, we get our prior authorizations and away we go. We can start services. And very much like the process that Leslie discussed in a prior slide, the time frame on this can be very different for people. Some people have issues with their Medicaid eligibility, which can slow this down. Sometimes people have problems finding providers. That can slow the process down. So this is very individualized, but this is a very generic overview for that.
If you don't mind interrupting, just I'm trying to grasp everything, and I'm sure we were trying to understand the whole process, and
Yes.
it can be rather complex. And I don't mean to interrupt your presentation, but I'm trying to get some clarity in going through this. One clarity is the money trail. When you said that people are just hanging out, has the money already been appropriated and that money is sitting there? Okay, so even though services have been delivered, the General Assembly has already budgeted that amount, but y'all haven't spent any money in regards to the services being delivered whatsoever. Is that correct?
There wouldn't be any spend on services being delivered until the end of that slide with the services begin balloon.
It would be the first 15-minute increment that was billed for an individual's care that starts the payment for their.
Okay. All right. My next question, then bear with me for a second. I'm trying to. I've got a scenario in my mind. So let's say my father calls up a adult home care service. This falls in that category, correct? For being a waiver for home. First, I want to clarify that. Adult daycare.
Oh, adult daycare, yes,
Yeah.
sir. Mm-hmm.
So when my father calls up, who goes out and does the assessment? Does the provider go out and assess that and get information, talk to their primary care physician, get the map, submit it to you all, then y'all look at that information, then y'all send somebody out there to verify that, maybe from the Dale program, I don't know. And then from that point, then you'll go through and say, all right, they're okay, they should go to adult daycare, they need the help and so forth. and then a case manager sort of oversees that and checks in on it. Is that roughly what I'm trying to envision, trying to grasp?
Well, really the first stop would be, again, a connect or going to the local community mental health center or local area development district to submit an application. One could certainly call an ADHD and go to tour and talk to the folks there and see if it's a good fit for them. But they wouldn't be able to actually start receiving services until all the other things had taken place. So again, the MAP 10 is one of the first things. Then the assessment, which is also by those third-party nurse assessors who come to the home and do an assessment. Then there's a level of care review based on the assessment that's completed. And if he meets the right criteria to receive that service, then he would be be prior authorized and be able to start going.
Does the individual, does a provider, can they go through and collect all the information? And if they are URAC certified, can they get that? Are they qualified in order to do that? They got everything right there, and then say, hey, this person does qualify. We got everything all teed up that they need to go in the program, and then y'all basically will go through and validate or that process again.
I'll speak a little bit to that one, Chair Fleming. So anybody can help an individual gather documents. We often find hard ways trying to find birth certificates sometime and things like that. Anybody can help gather the documents and doctor statements and things like that. Depending on which program that your father or your friend would be going to, we have a little bit difference in the assessors. So if you remember early on, I said maybe the two brain injury waivers and model waiver 2 are totally handled by us. So the HCBS assessors as well, we actually have the assessors that do HCB. Mm-hmm. So that's the program that you're talking about. DBH staff, Department of Behavioral Health, Developmental and Intellectual Disabilities, also assists with Michelle P. and SCL. So it just depends on which program that you're going in that might be the assessor. So CMS asks us, who are your assessors and are they qualified? And we have to designate specific people in the waiver that gets approved of who can do the assessment. So anybody can help gather those documents, but the assessment has to be completed by certain people.
Okay, well, I will stop right there because I know you got a couple more slides and I have some people want to ask questions. So I'll zip it for right now and then let y'all continue on.
Okay, thank you, sir. So in June of 2022, the LRC established a cabinet organizational structure, operations, and administrative task force. That is a mouthful. So that task force did some work over the course of 2022 and came back with a recommendation in November of the same year asking for agencies within the cabinet to do some internal work to identify and eliminate redundancies and barriers, especially in carrying out and overseeing and administering the 1915C waivers. So based on that, they asked for us to bring back a report and an action plan at the end of the year 2023, so December of 2023. So we did produce a task force report and action plan that was done in collaboration with Medicaid, Department for Aging and Independent Living, and the Department for Behavioral Health, Developmental and Intellectual Disabilities. So all three of our agencies got together to collectively identify and find ways to improve waiver administration. So that our responses came back with actually 10 opportunities for improvement. But for the purposes of this presentation and the interest of time, I've just pulled out the 5 initial highest priority opportunities for improvement that we identified for ourselves. And those are the ones that are on this slide. So eligibility enrollment and enrollment including waitlist management, participant-centered service planning and case management, provider certification and monitoring, data management and validation, and quality improvement systems. So again, the middle column there, these are the areas, these are sort of the tasks that we gave ourselves. These are the opportunities that we found. And we've done work in all of these areas. I do want to point out the little asterisk at the bottom of this slide, though, and you'll hear this a few times. So at that point in time, we were working to spend our American Rescue Plan Act funds, our ARPA funds. And CMS essentially had prohibited substantive changes in certain areas, and we could not make those changes until the ARPA funds were expended and we had an accepted and approved report back from the Centers for Medicare and Medicaid Services. So that happened. We sent our statement of our final report to them in April of this year, and we got the letter back from them in May accepting our report and sort of lifting some of those restrictions. So while there was work going on, we had the inability to do much about the recommendations and findings that we came up with, even for ourselves. So as you can see, we have made progress. We did conduct 2 key work groups to assess our current functional assessments within the waivers, those functional assessment tools, and identify options for waitlist management modernization. We have had regulations that have been drafted for quite some time that provide some clarity on eligibility and processes. Again, we've been in a place where we haven't been able to make those changes, but now we can start moving forward. There was an ask there about working with case management as we come out of the public health emergency. So we have integrated the option for telehealth visits once a quarter for case managers. So we've worked with them in that. We've also worked with our sister agencies, with Department for Aging and Independent Living and DBH, DID. We work with them monthly now. We have monthly work groups with them where we talk about certification, monitoring, and just implementing process improvements in general.
Ms. Hancock, if you don't mind, I've got 4 people. We got 2 more presentations.
Yes.
You're doing a nice job, and I appreciate that. But if you don't mind, go ahead and wrap it up so we
Yes.
can get the questions. I appreciate it.
Absolutely.
Thank you very much.
So let me set the stage for this one, and then I'll let you all read the slide. In April 2024, the Kentucky General Assembly requested that the Department for Medicaid Services conduct an analysis and assessment of the wait list process in Kentucky for the 1950C home and community-based services waivers. So we had to have that back to the joint committees in October of that year. This is the report that, again, we came up with. These are based on the findings from the assessment that we did work through, again, with our sister agencies in the cabinet. We came to 3 sort of actionable recommendations to better manage waitlist operations going forward. And we also had an additional layer of requirement with knowing that the CMS federal final rules that had come out, especially the access rule, had a direct impact on waitlist management and that process. So we've been able to incorporate that need as well. That is supposed to be in effect. The deadline for implementing those with the federal final rule in this area is July of 2027. So again, those are the 3 areas that we've identified for ourselves. There's a timeline to refer to there, so we're very much on track and well within our time frames for making progress in those areas that we identified. Thank you. Mm-hmm.
Thank you very much. I appreciate for cutting you off a little short, but obviously we do have quite a few folks that want to make a presentation and speak. And Senator Carroll, you have the floor.
Thank you, Mr. Chairman, and thank you for the presentation. Question specifically about the HCB waiver. Back during COVID, there were many kids that were approved for HCB that really didn't qualify. The qualifications for that were, I guess, expanded, a lot of gray area there. And I know probably every member here received calls once that ended about kids that were reassessed and they ended up losing their waiver. Two questions related to that. What happened to those kids? Were they, and I'm assuming they were already on an HC or a Michelle P. or SCL waiting list also? And did they just keep their slot on that waiting list, or were there special circumstances where these kids were addressed where they could continue some services? And I think it was either poor communications when those families received that waiver for those kids, or the parents just didn't pay attention to that, because I know that there were several parents who had some pretty severe disabilities, their kids, but not medical based, where it had been more HCB. But and you don't have to go through each kid, because I'm sure you don't remember. But in general, what happened to that population of kids?
Okay.
Just a big overview.
Big overview, yes. Many of those children were already on other waiting lists, whether it be Michelle P. or SCL. We did do a look back at all of those denials, reviewed every single one of them one by one, and overturned quite a few of those denials and reinstated services. We also reinforced with families that, especially for kiddos, there's EPSDT, there are state plan services that they can access. Are they tapping into all of the school-based resources that they can access? They would not have lost their slot on another waiting list. That would not have been impacted. But that's just as generically as possible.
Okay, and there seemed to be a problem with the assessments. And you all said with HCB that there were nurses out of UK. I understood that there was a private contract that was the cabinet issued to conduct those. CareSource, or
so we have a private. There's a vendor who does our utilization management.
Okay.
I think it's CareWise that you're thinking of.
CareWise,
Yes,
okay.
sir. Mm-hmm.
Okay, and there were some problems within that system and one particular assessor, if I remember correctly. Has that been resolved?
That has been resolved.
Okay.
CareWise at this time is not. Anytime that they feel like there's going to be a denial within the HCB waiver, they are sending that potential denial to Medicaid staff
Excellent.
First.
Okay.
We are reviewing every potential denial and then either saying we agree with your assessment or we disagree and you need to give the level of care.
That's good to hear. Thank you, Mr. Chairman.
Thank you, Senator. Senator Berg.
Thank you again. I'm sorry to have so many questions today. Two, how long, assuming you don't have a waiting list, how long does it typically take in this state to get approved for a slot? From beginning to end, from the time somebody applies to the time we say yes, assuming there's no waiting list, what does it take?
I don't have the exact averages here, but again, it would depend on the person and how quick they could get. So
Is it 7 days? Is it 7 weeks?
I would have to look. I don't know
Is
right
it
off.
6 months? We don't know.
No, I would say it's less than 6 months. You need time to go down to your local office just like anybody would and apply for, financial eligibility.
Follow up. I would be surprised from a department that's looking at efficiency and trying to improve your waiting list that you do not know what the average time of completion of a successful event is. That is something you should really look at because that could be minimized.
I understand. We did pull that information from maybe the interim joint commission. I'll see if I can pull that for you.
Thank you. And a follow-up to that question. You're saying monthly slots open up, monthly things churn. In the business world with money, you don't do things monthly. You do things daily, because you get interest on that money, and there's no way you're going to hold it for a month before you turn it over. Is there a way to not wait until the next month, to make your system realize that slot is available now and move it on a little faster.
I think for some things maybe we do, like deaths, that's
faster.
Faster.
And again, I hate to say it, it depends on the waiver. I was talking to, I forget which one it was, but one of them is actually releasing slots weekly. And I don't know if that turnover is more of a CMS thing. We'll need to look into that. But that's an absolutely fabulous call out. I do want to come back to the start to finish question. Like we said, the Medicaid eligibility and the waiver application process are two different things. So I would also consider they're simultaneous, but they're with two different offices, two different sets of things going on.
Okay. Thank you. If you don't mind, I'll cut you off. Let's see, Senator Meredith.
Thank you, Mr. Chair. Very quick question. This is specific to Michelle P. waivers. It's my understanding that special education advocates are being paid for these waivers, to help families advocate for educational rights for their children. If that's true, is this a qualified expense for these waivers?
Senator Meredith, can you say that again? I'm not aware of. Just say the question again. One more
Okay,
time.
it's my understanding that special education advocates are being paid from the Michelle P. waiver to help families advocate for educational rights for their children. And the question is that correct? And if so, is that a qualified expense?
I'm not going to be able to speak to that today, Senator Meredith, but we'll get the information for you and come back.
All right. Thank you, Mr. Chair.
Yes, sir. And just for I put a reference, I believe y'all have a report due in October. That was in 695. Is that correct? And what's that? Oh, it's last October. I'm sorry, this October.
What's the date on that?
It was the 2024 one in those slides.
Go back one.
Okay, Chris said it's in
Right
our
there.
it's in our
that one.
it's in our packet.
Uh-huh.
Okay, just want to make sure.
Yeah.
All right. For some reason, I thought it was this year. Any of it. Do you have a cost per slot per waiver?
I've got an average.
And if just in the interest of time, if you don't mind, just give that to the committee, give it to Chris, and we can have an idea what that is. Like I said, the cost per slot per waiver, that'd be great. And if you can do it over the past several years, that'd be great. Okay.
Oh, okay, several years. Okay.
You what? I think it is rolled over. Okay, thank you all very much. We appreciate it.
The process from application.
Steve, you need on your you're not on or something. Or
There you
pull it
go.
closer, and it's got to be extremely quick because we've got two more presentations.
Right. It's gonna be
and
real
we got
quick.
30 minutes.
Less than that. My question is, the process from approval, application, and you go through the process, is that driven by CMS guidance or is that Kentucky guidance? The steps, the reports, the assessment tool?
Yeah, the process has been approved by CMS.
Been
The
approved.
whole process is
Okay.
approved by CMS in the waiver. So any changes that we would make to that, of course,
Gotta go.
need a waiver amendment.
Okay. All right. Thank you all very much. We appreciate it. Speaking with Mr. Shannon, you are up, and Amy as well. If y'all don't mind, when you get settled down, introduce yourselves. I'd like to see if we can keep this within 10 to 12 minutes, because I know
I will try my best.
I appreciate it. We still have public comment, and then we need an update from the secretary.
My name is Amy Stade, and I'm the CEO of the Kentucky Association of Private Providers.
And I'm Steve Shannon, the Executive Director of CARP, Association of 12 of the 14 Community Mental Health Centers.
Sorry, I'm just getting my notes situated real quick. Thank you so much for allowing me to be here today. I really appreciate it. I'm here to talk about 1915C waivers. As you know, they're a cost-effective alternative to institutional care. I did want to note that these services are 100% funded by the Medicaid program. There are no private insurance options for 1915C waiver services, and they're home and community-based, obviously. Just a quick overview of what we're going to go over today. First, the 2020 and 2021 1915C waiver interim legislative task forces. 2, the waiver rate study. 3, waitlist phase-out plan, which Steve will go over because he knows math and I don't. And 4, just a final recommendation slide. So in the interim of 2020 and the interim of 2021, there were 2 legislative task forces done. Those finding and recommendation memos are in your packets. In 2020, it was the Exceptional Supports / Crisis Services Task Force, and that addressed the population that really is quite difficult to care for through 1915C waivers. They're incredibly difficult to care for. They're often not well suited for the services that we currently have. And we're talking about less than 100 people total that are in our waiver population right now that fall into that category. The second task force was the 1915C Waiver Services Task Force. The result of that bipartisan task force was 6 findings and 15 recommendations. Again, you have the full findings and recommendations, but I did want to quickly highlight 2 things. 2 findings. 1, the task force found that providing services in the home and community-based setting is more cost-effective than institutional care. And 2, that there is a well-documented 1915C waiver workforce crisis that is largely driven by low wages. 2 recommendations of that task force that I wanted to highlight are, number 1, there were 4 separate recommendations of that task force related to the need for crisis and exceptional support services, again, to really target that population of less than 100 individuals that are not really well suited for the current system of services available in our waivers. 2, the task force recommended that we have regular analysis of reimbursement rates with a focus on COLAs. And 3, that bipartisan legislative task force recommended that we develop strategies to significantly reduce wait lists. One of those strategies is creating emergency criteria for all of the waivers. I did want to note that to date, most of these recommendations have not been implemented. The rate study. So in your packet, you have a document that is entitled 1915C Medicaid Rate Study Timeline and Issues. It is a very in-depth analysis of the timeline of the rate study and the issues identified. I'm going to give you a very brief overview of that timeline and those issues. First, I just want to note that the rate study was initially begun in 2017 and was not implemented until January 1st, 2025. That's an 8-year process to get through this rate study. In November 2022, the preliminary rate study results were released and posted online. In January 2023, that rate study was removed from the internet and was no longer available for view for the public. Between February 2023 and June 2024, no action was taken to implement the rate study. During the 2024 regular session, the General Assembly appropriated about, I'm rounding, $94 million to implement the rate study. After the General Assembly concluded that year, the Cabinet for Health and Family Services announced that, quote, after careful consideration and deliberation, the department decided and the General Assembly funded an increase to only implement 70% of the benchmark rates established by the rate study. This meant that a majority of the rates were implemented at below 100% of the benchmark rate. So, with that in mind, we have identified a few issues with the rate study that I would love to talk about. Number 1 is that out implementation, the rate study was out of date. Neither Guidehouse, which was the contractor who performed this rate study, nor the cabinet inflated the reimbursement rates set by the rate study from the anticipated implementation of July 2023 to the actual implementation of January 2025. In fact, Guidehouse, the contractor, noted this in the rate study report and said that the cabinet should inflate those reimbursement rates from the original anticipated implementation of 2023 to the actual implementation of 2025. That was not done. Just to note, inflation from June 2023 to June 2024 was 3%. 2025 inflation is expected to be 2.3%. So we're already about 5% underfunded, while the rate, and that's at 100% implementation. We're below 100% implementation for the majority of rates. Issue number 2, there is an appropriation discrepancy. The rate study report contained a fiscal impact projection demonstrating that the rates as implemented on 1/1/25, the rates exactly how they were implemented on 1/1/25, would cost $68 million in general fund dollars. The Cabinet for Health and Family Services appropriated $94 million. So we're confused as to why many of the rates remain below 100% implementation, given that the General Assembly gave the Cabinet for Health and Family Services about $27 million more than the estimated cost for implementation. Number 3 is, and please, you can stop me anytime. I know I'm going through this quickly. Number 3 is inflation. So the Cabinet did not address, the rate study did not address future inflation at all in the rate study and how to deal with that. Once set, these reimbursement rates will remain stagnant for the foreseeable future. These providers have no ability to raise additional funds for themselves. There's no other billing source, so they can't offset losses by engaging in other lines of business. So we have estimated that by 2028, the 1915C, the benchmark rate, so that 100% level, will be at a minimum 13% underfunded. And then there were significant wage inflation errors contained in the rate study. So a portion of the rate in the rate study has to do with wages, what wage you can pay your employees to do the job. The rate study report claimed that the wages used to determine the benchmark rates were inflated to 2023. They were, in fact, not. In this timeline and issues document, I have several screenshots from the various rate study reports. They are also footnoted, so you can note the timelines. But essentially what they show is that in the 2022 preview of the rate study report, the wages used are exactly the same as the wages used in the resulting rate study report, meaning that they were not inflated. Moving along, the wait list.
Again, Steve Shannon, I'm going to talk about the wait list. This is information we presented actually in 2023. There was a group of people that got together, advocates, to end the wait list campaign. I'm getting too old. This is my 3rd iteration, now 4th iteration of End the Wait List campaign. Dr. Schuster ran that up. She does all advocacy for the state on every issue, I believe. And we looked at what could be done to end the wait list. And my good friend Amy said, I can do math. After that, I don't have much skills, but I can add, subtract, multiply, and divide with the best of them. So I came up with a model to figure out what does it look like to end the wait list. And there's a 2-year model, a 4-year model, a 6-year model, and an 8-year model. You can just move to the next slide.
Do you want to do that?
Yeah, so this is what, just for informational, if you do 50 people a year, HCB is going to be 105 years till we go through the current wait list. Michelle P., 193 years, SCL, 74 years. Obviously, it's more than that. We want to greatly appreciate. Again, I've been doing budget stuff for a long time. We've never seen as many slots funded, ever, than we did last session, in 24, the budget, biennium session. Never. 1,925 slots. That is a huge, huge lift, and we greatly appreciate that. That still, the wait list numbers have increased since then. So my guiding principles when we talked about this is the 2, 4, 6, 8-year model. Should be noted, new names will be added. So it's a point in time. It's a Polaroid, not a video of what took place, and it will continue to grow. We can do a calculation to include that number. Go on to the next one. So we looked at what it is. We also did a phase in. So the first year, you don't fund everybody because you're not going to be ready to fund everybody. It's going to take time to get people ready. So you phase it in 1/12, so if you do 1,200 slots, theoretically you do 100 a month. So you have fewer than 1,200 times 12, right? You have fewer months of service because you phase it in over time. You really end up with about 54% of the total cost in year one. Year two, you have the full cost, the full freight of the biennium, and you do it that way. So model was based on that, just using the 1/12. If you look at data from the cabinet, they used a 3-month phase-in for the HCB waiver, 3 months phase-in for SCL, and went 6 months for Michelle P. So it's not unrealistic to use a phase-in model to really mitigate some costs during year one of any biennium budget session. Full cost year two. Year two, new people, obviously, is less than the. These are the match rates we use, just so people understood the math. And this is what it looks like. And this, again, this is the 2, 4, 6, 8 year model. We haven't updated because we had this information. We don't know really where we're heading. But I recommended to the group we do an 8-year model. I don't think a 2-year model is realistic. I think it's hugely expensive in 2 years. You're looking at State General Fund, $234 million in 2 years. I'm not so sure the provider community can meet the needs of a new almost 18,000 people in 2 years. That seems unrealistic. But can you set a target that you end the wait in 8? Can you make that determination so people, there's someone on the SCL wait list, based on the data we got from the cabinet just recently, has been there for like 2,800 days, almost 30 years. I mean, they've been there a very long time. Don't know why, right? We have SCL has emergency, has urgent, and then future planning. How long should people have to wait to provide services? They're getting Medicaid services, they're Medicaid eligible, but that's really state plan, some supports. They're not getting the residential options, they're not getting case management, they're not getting some services that are unique to waivers. So how long should people have to wait? My opinion, 8 is a fair number, and you do it. So you know what's going forward, what you're going to fund. And I think with expectation and planning that the provider community across all waivers can serve another 3,180 people based on that data. A little bit higher now. But once you know what's going to happen, you can gear up and be prepared. If you don't know, again, the 1,900 was wonderful. This would be more than that, only by about 1,200 slots over the biennium. That's really the expectation. I think it's fair. I think families want to know that number, have an expectation of what that looks like to end the waiting list in 8. And that's really what I think it's, again, families come to me, come to Amy as well. I'm sure Dr. Schuster, when will I get services? When will it happen for my child? What does it look like? And if we can say 8 years, at least, it may not be wonderful, but it's better than we don't know. We don't know, you know.
Okay.
And then just quickly, I wanted to go through our recommendations. Number one, implement the recommendations of the 2020 and 2021 task forces. 2, require the Cabinet for Health and Family Services to perform an annual analysis of 1915C waiver reimbursement and direct care worker wages and report those results to the General Assembly. This was also roughly a recommendation in one of the task forces as well. Implement regular and required cost of living adjustments for 1915C waiver services tied to the Medicare Economic Index or another economic index. Include funding for 2468, waitlist phase out. Require the Cabinet for Health and Family Services to increase all waiver reimbursement rates below the 100% threshold to 100%. And to make that easier, I have Excel spreadsheets of every single service and every single waiver that is funded below 100% and what that funding level is at. And I did want to draw your attention to 2 services. They are the residential services, which are in the Supports for Community Living waiver and the brain injury waiver, which are the cornerstone services of those waiver. SCL is a residential waiver. You get in that waiver because you need the residential service. So the residential services in SCL are funded at 83% respectively and 70% of the recommended rate. Those hugely need to be funded at 100%. It is paramount to the survival of those services, which again, cornerstone service of that waiver, that those be funded at 100%. And lastly, require the Cabinet for Health and Family Services to update all waiver regulations to accurately reflect the current regulatory standards, because our regulations are very much out of date and do not reflect current operating procedures and regulatory standards. And any questions, we'd be happy to answer.
Thank you very much. We appreciate y'all coming and making a presentation. It's very, very helpful. I think couples are familiar with a lot of these challenges that we have. But I do appreciate y'all coming and reiterating that. Is there any questions from the board? Senator Carroll.
Thank you, Mr. Chairman. Amy, what is your understanding of why the rates weren't increased to the 100% level?
I am uncertain. The rate study document itself says that to implement the rates as they were implemented on January 1 of this year would cost $68 million. It is our opinion that 100% of that $94 million should have been used to improve rates, not pay for to hold this program steady. The General Assembly may have a different idea. It was your bill, not mine. But, we don't know.
Mr. Chairman, could we ask the Cabinet to address this at the proper time?
Sure. We'll make a note of that and probably just give them the time. We'll probably have them come back and make a presentation. So we'll contact with the Secretary about that. Thank you, Senator. Good question. Any other questions? Very good. Thank you all very much. We appreciate it. And second to the last item is an update on the Rural Health Transformation Fund by Secretary Stack.
Good afternoon, Mr. Chair, committee members. This can be relatively brief because there's not a lot that's changed. So CMS has not yet released its notice of funding opportunity for the Rural Health Transformation Program. We were updated just over the weekend at a meeting I was at that we should expect it now in the next 9 business days, so that would be September 17th. So we should have it, if that holds true, by September 17th, but that's next week. It was clear it won't be this week. We are also still clear that the application will be due in the first half of November, so we know not later than November 15th, at least based on the first half of November. They will issue awards by December 31st. We don't know how quickly the funds will be available to draw down after that, but December 31st, by law, they're supposed to tell us before January 1st, and so I think they intend to try to fulfill that. There have been a number of meetings and briefings that the CMS leadership, including some Dr. Oz himself, have been part of for governors, secretaries, and others, and I've attended some of those, as have our teammates. We have received from the solicitation letter that I sent out close to 40 responses so far from stakeholders around the state, which we have summarized and are reviewing and looking. We're grateful for the input that we received. Some of it can be actionable, some of it not. And I just emphasize that in all of these calls with federal leadership, a number of things have been very, very clear. This money is not to be used just to pay for clinical services. They've been explicitly clear that that is going to score you very low and they're not going to look at that favorably. It's not to replace lost income. This is specifically not just to give to people who are losing income to maintain existing services. It's not to replicate programs already supported by other federal programs. So if there's other federal programs that are in place and there's funding being provided, they intend for those vehicles to continue and for us to come up with new things that are different. Things that must be, they expect it to be transformative, more efficient, to use technology to try to help things be done more efficiently and more effectively, to improve health where possible, so supporting the Improving the Health of America efforts. And they've emphasized repeatedly there has to be a sustainability path. So things that are proposed to us that may otherwise be good ideas or programs that are being done, if it's things where, I'll use as an example like loan repayment. I don't think they're going to look favorably on loan repayment because if we use the money for loan repayment to recruit people into the state, there's no money to continue a loan repayment program after this money is gone. So there's not a sustainability path. So someone would have to convey how they're going to sustain the effort clearly and compellingly after the money's gone, if that were going to be an avenue. So one thing I will say, we would love to be inclusive and collaborative. We're going to have 6 to 7 weeks, just to put this in context, 6 to 7 weeks to write a plan with concrete action steps for how we would propose to transform rural health care. Every state's in the same boat. I was at a meeting with 24, 25 of my colleagues from other states just this past weekend. We're all in the same boat. So this is a challenge. It's a huge lift. The feds acknowledge it's a huge lift, but notwithstanding that, it's in law, these timelines, and so we're all having to move quickly. So to all of the Kentucky stakeholders, anyone in this room, anyone who's hearing me, we do want to be participatory. We do want to collaborate with folks. There are very real constraints that make the kind of collaboration that we might otherwise do impossible on this time frame and at this scale. So we will do the very best we can to make use of the input we've received, and where we have specific ideas where we can do focused outreach to try to talk with those communities that might be important to delivering the results, talk with them. And we'll keep you updated as we go forward on how things unfold. But things will start moving very quickly when we get that notice of funding opportunity, because we need the specifics in order to actually then spec the project and write it to the way they want to receive it.
Well, very good. I know, Secretary, you're working feverishly and trying to pull this stuff together. At the last meeting, you gave an update. There's an RFP that you said that you issued. And you might already have that. I might be jumping the gun. You might have.
No, I can tell you now.
Yeah, if you don't mind. Yeah, just explain. Explain who'd you awarded, how the money is split, where'd you find the money, those sorts of things.
Sure. So, so the first thing is, remember, the cabinet is ultimately responsible for putting this proposal together. So the consultants are there to support and assist. So it's not their output. It's going to be our output with their help. So we have I guess I'd describe it as a master agreement with 10 vendors on it that we can do a streamlined approach for proposals. We put out a request for proposals. 8 of the 10 vendors in that master agreement responded. 2 did not submit proposals. From that, we picked one using a standardized scoring process like we do for any competitive procurement. And Public Consulting Group was the vendor that was selected. Their contract we've started work with them at this point in order to get underway. They've been helpful for things like summarizing the input letters that we received and things like that, where they can kind of provide a task that makes our work more efficient as we're trying to make decisions. And I think you had asked for the contract amount. Now remember, this is a contract for all of HR1. So there's the SNAP admin changes. There's the work requirements that will happen for SNAP and for Medicaid. So they have other aspects. So the phase 1 of this work is $1,085,000. This, I think we'd anticipate, would be a 50-50 federal-state cost. And this is just one of those things we have to find a way through our administrative budget to cover the state cost. But and so then if we get funding for the Rural Health Transformation Program, of course, we're allowed to use up to but not more than 10% of that funding for administrative cost to oversee the program, and I anticipate we'll use a substantial, if not all of that, to actually administer the program, and the other 90% would go out across the state, or more than 90%. Obviously, we won't take more than we need.
Okay, pretty good. Any questions for the Secretary? Covered my questions. All right, well, very good. Thank you very much, sir. We'd have one person who has signed up for a public comment. Mark, and forgive me if I mispronounce your last name, Lapame. Okay, I get a brownie point for getting close. And go ahead if you don't mind. Just introduce yourself. And you have 3 minutes. Yes, sir. Make sure it's green and the mic is close to you. There you go. I can hear you.
My name is Mark LaPalme. I suffered from addiction for 27 years before achieving sobriety in 1999. Founded the Isaiah House and served as CEO for 23 years. Today, I lead Sober Life Consulting and serve as senior consultant for Altogether Recovery in Danville, Kentucky. Kentucky used to be a leader in the addiction recovery field. We expanded Medicaid to cover treatment, invested in community programs, and showed we were willing to put resources into helping people get better. Too many programs today put profit first, including nonprofits, leaving patients behind. What began as a system of care has in many places become a business model built on cheap labor and low-value services. One major problem is the use of people in early recovery as cheap labor. In some facilities, they work full-time for as little as $75 a week, kept on food stamps, kept on Medicaid, while companies bill Medicaid for their services. That is not treatment, it's exploitation. Another problem is the weakening of peer support. Done right, peer support is one of the most powerful tools in recovery. But here, Medicaid has even been billed for free AA meetings. The General Assembly also created temporary peer support specialists who can bill Medicaid with almost no qualifications, sometimes at the same rate as licensed clinicians. The result is predictable: more low-value services, worse outcomes, and patients stuck in cycles of relapse. A third problem is the abuse of psychoeducation. Psychoeducation simply means giving basic information about addiction, which should already be a part of counseling. But Kentucky expanded it so group sessions could be billed, making it highly lucrative. Spending jumped from $40 million in 2023 to $168 million in 2024, while dollars for therapy and residential treatment declined. The pattern is clear. Providers are rewarded for volume and not value. They bill Medicaid for low-value services while paying those who deliver them next to nothing. It has created a perverse incentive where the less providers invest in real care, the more money they make. That is why we have seen FBI raids, indictments, and even the state's largest provider under federal investigation. Kentucky can change course by focusing on three priorities. 1, require fraud prevention training and strengthen enforcement. 2, incentivize licensed clinical care, not cheap labor. And 3, clear the backlog of state investigations so bad actors cannot keep operating for years. Kentucky once set the pace for recovery innovation. We can do it again, but only if we value people above profit. Thank you.
I need to turn my mic on. Thank you very much. Mr. LaPalme, I appreciate your comments. You're spot on in terms of your points you've made out in terms of fraud prevention, the stand-down list, which I understand it is, and then also looking at the labor to go in that. So your points and your comments are very well taken, and we do appreciate that. And congratulations for maintaining your course, and we are proud of you, and we'll keep your thoughts and prayers and maintain that course.
Thank you. I look forward to working with anybody on those issues. Thank you,
sir. Pretty much. That sort of concludes the meeting today. If there's not any questions, concerns, Chris, when's our next meeting? Our next meeting is September 24th. And Dr. Schuster, do you have a quick question?
Yeah, I wondered if there was going to be an extra meeting in October. We were told at one point that there might be. Getting the schedule ahead of time as much as possible is really helpful.
Yeah, and Senator Adams and I are talking about that. We are thinking about going down that path, yes. But we'll try. We'll get with Chris and make sure we get something nailed down soon. But thank you for pointing that out.
The other thing is that I happen to be studying the interim calendar just in my spare time, and I noticed in November that our meeting had been changed by a week, and it had gone from a 3 p.m. to a 9 a.m. meeting, which I would not have known had I not been studying the interim calendar probably at 3 in the morning. So it would be really helpful if those changes are made, if we could get a little memo about that as soon as you all make those changes.
Sure, that's a good point.
Thank you very much.
The staff, yes, ma'am. All right, without any questions, we stand adjourned.